So we're just going to start today, guys, by introducing our guests. So we have Professor Paul Harrison here with ourselves. We also have Dr. Maxime Taquet. We also have Dr. Tim Nicholson, and we have Tom, who is a lived experience during COVID. So if, guys, you want to just introduce yourselves and just say a little something about yourself, you can go ahead.
Okay, good afternoon, everybody. I'm Paul. I'm a psychiatrist in Oxford, as Coco said, and I'm an academic psychiatrist, which means I spend some of my weeks looking after patients, some of my time teaching, and some of my time doing research, including most recently some of the aspects about COVID and mental health, which we're going to talk about today.
I'm Max. I'm a psychiatrist, and I'm also an academic psychiatrist. I also spend my time between seeing patients and doing some research. And lately I've done the project that Paul just mentioned about the link between COVID and mental health.
Hi, I'm Tim. I'm a neuropsychiatrist, so I specialise in the overlap between neurology and psychiatry, and I work clinically across a broad range of disorders, but increasingly in COVID, so people who have been affected by COVID, with brain effects, long COVID, but also a bunch of other related disorders, and I do research in the overlap between neurology and psychiatry.
Hello, my name is Tom. I am part of the Long COVID SOS campaign group. We help people with long COVID. I also run my own business here in London, and I study a master's in philosophy. I caught COVID back in March of this year and have had quite a protracted journey through the initial illness, and now find myself in neurology, and so I'm interested in this webinar for that topic.
That's great, thank you. So although we are all in the same storm, I guess, with COVID-19, we're not all in the same boat. We've all learned that different groups of people are at particular risk for worsening physical and mental health through the pandemic. And conversely, that some people have seen improvements in their mental health through it. Exciting new research from University of Oxford and the National Institute for Health Research, Oxford Health Biomedical Research Centre shows the relationship between COVID-19 and mental health problems are more also direct. Before we knew, there are more physical risks for COVID-19, such as age and pre-existing medical conditions. But this study have also established there are psychiatric risk disorders. The research suggests that those who have survived COVID-19 are more likely to receive a diagnosis of a psychiatric disorder within 3 months. So obviously, guys, that is really soon. And people who have existing mental health conditions are more likely to catch coronavirus. We're joined by some of the researchers today who have studied, and we're very lucky this evening to have those with us, and also Tom, as we've all discussed, during having long COVID and going on to talk about his experiences. So firstly, we're going to start by talking with Tim. So Tim, we spoke initially about how COVID is indirectly impacting mental health, but could you start by talking about how illnesses such as COVID-19 can directly affect the brain?
Thank you. Yeah, so this is a very interesting area, and something with a new virus like this we didn't know much about. We had some clues from previous coronaviruses, so SARS and MERS, so severe coronavirus infections, which are much less, far fewer people affected, but there were some clues that affected the brain quite a lot in several ways, both acutely and in the long term. But as this pandemic has taken shape, there were reports quite early on out of China, and then Italy, and then Europe and the US, showing that there was some quite severe brain effects of this disorder. It's quite hard to unpick how much is coincidence and how much is actually directly due to the virus itself. But there are several mechanisms by which this might be occurring. There was a lot of concern initially that the loss of smell that so many people get was a sort of indication of direct effects on the sort of olfactory system, the olfactory nerves, and therefore a route to potentially affecting the brain, and therefore sort of direct brain effects of the virus itself. There's been quite a lot of evidence that's come out, some mostly reassuring that doesn't often happen, and the virus isn't often found directly in the brain, although it's been reopened by a very interesting Nature neuroscience paper that came out a few days ago saying that might be the case. But more of the thoughts are that it can occur through inflammatory processes. So the body's immune system will react to the virus and cause inflammation, and perhaps later on even antibodies against the brain, causing neurological and neuropsychiatric, even purely psychiatric psychiatric symptoms. And so those are the sort of main methods, but we also need to be aware of the fact that having treatment in hospital has reasons to affect the brain as well. So having low oxygen, being intubated, being in intensive care can affect the nervous system both peripherally and centrally and cause symptoms. And the other thing that's coming out a lot is sort of delirious states acutely. So people are very confused, and that can be how people present initially, particularly in the elderly. So they might not have any respiratory symptoms, but confusion and brain sort of dysregulation is the sort of key initial and often the main or only symptom. So there's a dissociation between the respiratory symptoms, which we all know about, and that's the main thing we think that's harmful to us, but people can present with strokes due to blood clotting problems as well. So there's a whole host of different ways it can affect the nervous system.
Is this common, would you say, in other physical illnesses, like such as the flu itself or other coronaviruses?
Flu doesn't often cause these sorts of problems. It can cause very rarely some brain effects, but it's not really a common complication. But these other more less common but more severe viruses, the SARS and MERS coronaviruses, they can do this as well. So even though we haven't got as much data on them, we've got slightly more longer term follow-up compared to what we got with COVID-19. But yeah, it's definitely something that can occur with those. So we wouldn't be surprised. And there's also the Spanish flu, is associated with some rare but potentially very serious things like encephalitis lethargicus. That's the sleeping sickness that was sort of with movement disorder problems that was popularized in the Awakenings film and book by Oliver Sacks. So there's a possibility that rarely with these common, what essentially affects millions of people, that you might get these rare things occurring quite a lot because of the sort of scale of the people infected. So we need to be aware that this can happen. There's also some concern that potentially viruses can affect developing fetuses in people who are pregnant as well. So there's been concerns that there are rates of psychosis and schizophrenia later, many years down the line, that might have been associated with the Spanish flu pandemic.
That's really interesting to know. Thank you for that there, Tim. So we're just going to ask a question now for Paul. So what prompted you to explore risk factors for COVID-19 from people's mental health?
Well, I guess like everyone on this call and everyone in the public, we've been worried that there may be an association that COVID, either directly, as Tim's suggesting, indirectly, or just through the kind of stressful environment everyone is living through at the moment, there might well be some adverse effects on people's mental health. And the study came about really sort of opportunistically because we happen to have access to a very large number of health records from people in the USA. When I say large, I mean about 69 million people.
Oh, wow.
About whom 60,000 had a confirmed diagnosis of COVID at the time we did the study. And so we really asked very simple questions, which was, how many of those people who'd had COVID were then getting a psychiatric diagnosis in their health records in the 3 months after they'd had their diagnosis of COVID? So the first half of the study was about that question. And we tried to not only say, if you've had COVID, what are your risks of getting a diagnosis? But again, coming back to Tim's point, how much of that was specific to COVID and how much was simply a consequence of being ill with something else during the COVID period? And so I think Max will talk a bit more about the results, but essentially we came up with some estimates of survivors' risks of mental health problems and also evidence that, yes, COVID is doing something above and beyond simply the non-specific effects of illness and living through the COVID period. The second half of the study, and it probably helps to think of them as separate studies, was that we asked the opposite question using the same database, and that is, if you had a history of a mental health diagnosis, did that affect your risk of getting COVID? And I think that side of the paper surprised us a lot more because, as you said at the beginning, we did find really quite robust evidence that having a psychiatric diagnosis in the year or even the 3 years up to the COVID onset, that increased your risks of being diagnosed with COVID by 65%. So not a trivial excess of risk. When we first found that, we thought, well, maybe that's because people with mental health problems, unfortunately, more likely to have physical health problems too. So it might simply be a marker of that. But in some very kind of clever analyses that Max can talk about more, we tried to control for all the known physical risk factors for COVID and match those between the groups with and without mental health problems. And essentially, the results were unchanged. So we don't think the results can be explained away by physical health. I have to say the explanation for why there appears to be this association between poor mental health and COVID, I think requires a lot more research. We weren't able to address that in this particular study, but it's certainly given, I think, us and others food for thought about both the mechanisms but also the implications of the observations.
Definitely. Yeah. Thank you for that. That's really interesting to know. So moving on, we do have a question for you next, Max. So in as simple terms as possible for all our viewers, could you talk through how you found the data and analysed it?
Yes. So as Paul just mentioned, this was very opportunistic. So we had access to data from electronic health records. So this is essentially everything that your doctor writes in your records whenever you have an encounter with a healthcare professional, and that was provided to us, and so we were able to then look within that large data set for associations between a diagnosis happening at one point in a health record and another diagnosis occurring at another point. And so what we looked at is, well, is having a diagnosis of COVID at one time point, does that predict having a diagnosis of a psychiatric illness within the next 3 months? And so that's what we did. But then importantly, as Paul mentioned, we wanted to make sure that any sort of association that we were finding is not a sort of generic association between being ill during the pandemic with any illness, not just COVID, and a psychiatric illness. And so in order to look at that specific question, we defined other group. We looked at other groups of patients having had other illnesses, such as the flu, but also skin infections or gallstones or renal stones, or even a fracture of a large bone. And then we looked at those other groups and we compared the groups, the group of patients who had COVID and the group of patients who had other illness in the same time period. And we looked at within the 3 months after their illness, are the group of patients with COVID more likely to have a psychiatric illness? And what we found is that indeed this was the case. It seems that 1 in 5 patients who have COVID go on to have a psychiatric illness in the 3 months after their illness. And that's well above what we see in other groups of patients. So that's about 50% to 100%, so almost twice as much as what we see in other group of patients. And within that 1 in 5 patients, 1 in 4 of them, this will be the first ever psychiatric diagnosis, at least from what we see in their health records. So in other words, those are 1 in 4 of them never had a psychiatric diagnosis before. So they would be the first psychiatric diagnosis after COVID. And so this is how we run the study.
Yeah, wow, that's really interesting. Thank you for that, Max. So we have another question for you now, Paul. So just going back and forth there. How do you find your studies relate to other findings about the role of inequalities resulting in certain groups being disproportionately impacted by the pandemic?
Excuse me.
Yes,
yes,
okay.
That's a very important question. And one of the limitations of going to health records as your source is, of course, they don't have very good information on people's living circumstances, socioeconomic factors, and so on. So although, as far as we could, we tried to see to what extent those sorts of inequalities, again, might be contributing to our associations between COVID and mental health. Okay. To be honest, I don't think we can do that very well. It really needs a different sort of study where you know a lot more about the lives of the people who you're studying. So our study was very strong on the medicine. It was not strong on those kind of issues. And I think my guess is quite a lot, but maybe not all of the associations we saw between having a mental health problem and the risk of COVID might well be explained by some combination of those factors that we simply couldn't measure in our study.
Okay, thank you for that. So now we have a question for all of you. So answer one at a time or together, however you fancy. So we know further research is needed here, but is it the mental distress of catching severe coronavirus impacting mental health negatively, or is it likely that COVID is affecting the brain?
Well, shall I kick off? And I'm sure others.
Yeah, sure. Yeah, definitely.
Well, again, first thing says, from our study, we can't answer that question. We were reporting associations between observations, and both those mechanisms are quite possible from our data. Yeah. We're trying to look further into those data and look in different ways to try and get a handle on it. My guess it'll be a bit of both. Perhaps one of the interesting observations is, although we tried to stratify our patients into how ill they'd been when they had their COVID, because you might think that a direct effect on the brain would be more likely in people who've been really ill when they had their COVID initially. And although there was a weak association with that, I was more impressed by how many of the mental health difficulties afterwards were still seen in people who didn't appear to have needed much healthcare when they had their COVID. Now, that doesn't make it necessarily the case that the effects, the longer term effects of mental health are indirect, but it's perhaps not quite the relationship I would have expected if it was mostly being driven by a direct biological mechanism of the kinds that Tim introduced. But again, that's totally my opinion. We don't have data.
Yeah, interesting. Yeah, thanks. Next, guys, whoever wants to go next.
I think I would like to say from a patient perspective, this is a really important question to answer because it has a fundamental impact on what a lot of us have experienced in seeking care during the illness, and the way that we present to doctors can be ambiguous where the effect is happening due to a biochemical kind of brain process or due to stress of the illness and so on and so forth. And I think there's quite often been a temptation in general practice for the symptoms to be explained as anxiety because of the way that the pandemic has played out and so on and so forth, when actually there's possibly a deeper mechanism at play. So I think in terms of the patient community, I think that's a really important one for us to be able to unpick.
Thanks. So it's a critical question, and I would agree with Paul that I think it's a bit of both. So not just an individual can have one or the other. I think you can have a combination, and sometimes a transition from a sort of biological effect to something that might have more psychological components over time as well. So I think that's possible. I think what we do know is that the direct brain effects aren't, apart from the acute deliriums and potentially some strokes and things, there's not a vast number of people with very severe psychiatric or neurological problems. We've been doing sort of early studies, surveillance studies, to try and work at the coroner study, which has sort of been set up, a sort of sleeping study that was ready to go as soon as there was a sort of a virus that got out of the bag like this one has. And there's definitely case reports of almost anything neurological or psychiatric resulting from it, but they're not sort of we're not being overwhelmed by something a bit like encephalitis lethargica that might have come out from the Spanish flu. So I think we're not getting a vast amount of that, but it's certainly in the acute phase, these cognitive impairments are very, very common. But what we are getting is this very big signal of the long COVID situation, which I think Tom will talk a bit more about, but it's something we don't fully understand, and it's a sort of urgent healthcare crisis that needs addressing. And this week we're all preparing grants, and Tom is helping out to co-design these to try and urgently address this issue. Is this an inflammatory problem? Is it something else, or a combination of things that is leading lots of people who weren't initially severely ill enough to be hospitalized mostly, but have been left with very chronic severe symptoms? And I guess before I lead into Tom perhaps talking about his experience, if that fits, is I had COVID back in April, and I definitely had I really struggled with brain fog for a month or so, where I really struggled to sort of, I was sort of 70-80% of my cognitive performance, I would guess, for quite a long time. And it took, and there's a very sort of undulating, seesawing sort of recovery from that. So I think it's very interesting to have lived a little bit of that, but nothing like what people with long COVID are experiencing. But it was a small amount of perhaps what they're experiencing. Definitely.
Thank you for that there, Tim. And on to you, Max.
Yeah, I think I'm mostly going to repeat what's been said, but it's not an either or explanation. It's very much likely or possible that the two explanations are at play. And as Tim just alluded to, it might also be that one leads to the other, and there's some interplay between the two as well. I think an interesting question, which we don't have the answer to, is also whether if one component is more present in one individual compared to the other component, that is the psychological versus the biological, if you can name them that way, and whether the treatment would be different. And it might well be that the treatments are working exactly in the same way. That is, if you suffer with anxiety, it might be that the treatment for anxiety that we give to patients with anxiety, whether or not they've had COVID, work just as well. And so that's potentially a question that for patients is more relevant and very important. And we don't have the answer to that question.
Yeah, no problem. Thank you for that. Could each of you tell us a bit more how physical health and mental health are linked?
Gosh, I think the most important thing to emphasize is they are inextricably linked. Okay. And I think the minute you take what would be called a dualist view, you're doomed to both fail and also alienate people who understand that the picture is more complicated than that. Now, the ways in which body and mind interact are many, and they're both, if you like, direct nervous connections. There are hormones, there are chemicals, there are a whole range of well-established biological mechanisms. So none of us should be surprised that the two things interact. And we should, in a sense, approach every problem from both angles, because you're unlikely to solve any problem if you ignore one because of a particular prejudice or just ignorance about the importance of the sign. I'm quite sure that's going to apply to long COVID. We will be doing people like Tom a disservice if we don't take, if you like, the brain and the mind equally seriously, because it's an open question, you know, kind of what the mechanisms are, but both body and brain will be affected for sure.
Yeah, anybody else got anything to say on that? And you can either, if it's just in general, I guess, with the mental health, with the physical health, how they just intertwine in general kind of thing, if anyone would like to touch on that.
Just going to add that I think although this is horrific pandemic, I mean, there's a few silver linings, and one of them might be that the research that we're doing urgently at the moment might start to sort of be the sort of final nail in the coffin of anybody who wishes to separate the brain and the mind and the body. So I think we'll be able to unpick, hopefully, with this urgent research that we're doing, the interplay of these complex systems and hopefully finally get rid of that distinction between the two, which I think is generally very unhelpful.
Mm-hmm. Okay, that's great. Thank you. So we have another question here for Max. So Max, the study mentioned that people with pre-existing mental illness are more likely to have severe COVID if they caught it. What are the possible causes of this? And is it common with other illnesses?
So what we've shown is not quite that. So what we've shown is that they are more likely to have COVID. We don't know whether they're more likely to have more severe COVID. And you know, this question again sort of touches upon the why. Why is it? And that's a very important question. But again, that's not a question that we can answer with the data. So the only thing we can do is speculate about what might be the mechanism at play. So first, it's important to note that as you rightly asked, that's something that seems to be the case for other respiratory tract infection. So pneumonia, for instance, it's been reported that patients with a psychiatric illness or with a history of a psychiatric illness are more likely to have pneumonia. And there can be quite a lot of explanations. I think Paul mentioned one earlier when he said that perhaps this is a lifestyle factor. So what are people's life like? And that's not something that we did have access to. And so that's not something we can rule out as an explanation for the finding that we had in our study. It's one example of that, for instance, is that we know that patients with a mental illness, sometimes some of them at least, tend to smoke more, and it might be that smoking is a risk factor for having COVID, or indeed in that case for having more severe COVID. So that's one example among many. It might be that also it's more difficult for patients with a mental illness to completely self-isolate, simply because sometimes their social interactions is very much part of their support and their treatment, and so it might be for that reason that they are more likely to get COVID. But again, those are all speculations. We do not have the answer from our study.
Okay, then. So we have another one here for you, Max. So considering this research, if I have a mental health diagnosis, what should I do?
Well, I think as with all mental health diagnoses, you should seek help. As we've just sort of mentioned about the link between the sort of brain and the rest of the body, or between a psychiatric illness and physical illness, you know, those are illnesses that can be treat it. And in many cases, actually, patients get better. When it's anxiety, for instance, or depression, a lot of people get better. Some people get better on their own, just by waiting, with time. But a lot of people get better because they receive the right treatment, and that can be talking therapy, so that can be medications. And it's very important that if somebody has symptoms of mental illness after COVID, but also, without COVID, that they seek help, because there's treatment for it, and it would be a shame not to have access to that treatment.
Okay, that's great. Thank you so much for there, Max. So we have one now for Tom. So Tom, could you tell us about your experiences of long COVID and how it's impacted your mental health?
I can. So this question about whether there's a biological chemical effect and whether we're looking at a mental effect is one that I've lived through in my own body and experience, I think, over the last few months. I can give you an idea about
fab.
Give you an idea about how that played out over time. So after I got sick in March, initially I had very mild symptoms, which I got over in just a few days. Then I developed more symptoms after about 2.5 weeks, and the second phase was much more severe. My GP sent me to hospital, although I wasn't admitted because I didn't have low blood oxygen, which at the time was the beginning of lockdown. It was very traumatic to go to the hospital, see all the people in PPE and be around this kind of virus containment measures and all that sort of stuff. And then I didn't really get better as quickly as I thought I might. I had a lot of lingering effects over the following few weeks, but because of the stress of the whole lockdown, I live on my own, they all kind of merged into one. It was difficult to unpick. And now what happened to me was, after about 7 weeks from the initial infection, this was when things really took a turn for the worst, which apparently is a pattern in long COVID that happens to people, where after about two or 3 months, people kind of enter this new phase. And I think it was at that point where the problems really kind of took off, because I had a lot of neurological symptoms, which went beyond just sort of confusion. There was like numbness and tingling and all sorts of effects to do with the autonomic nervous system. So heart rate and breathing stuff. And it was very difficult when I went back to my GP, who had decided that I'd recovered, to convince him that there was something underlying going on here, that was beyond anxiety. And obviously long COVID was not a thing then. Nobody knew about it. Nobody knew about these effects. And so I had this sort of back and forth with the GP about, well, what is the cause of your symptoms? And I knew, I could tell in my own self, in my own body, that something was really wrong. But the GP and the external world, it didn't matter whether I went to the GP, whether I went to the hospital, the response that I got back was, your symptoms are caused by anxiety, and that they're mental. So it really it drives this kind of negative feedback loop between the symptoms and your mental health. And so it felt as though it wasn't until things kind of shook out a little bit later on that I began to be able to separate out, okay, so the mental aspect is kind of over here, and then the neurological symptoms are over here. And there's this interaction between the two that was actually very difficult to unpick. But this question about testing as well is one that, a lot of long haul patients didn't have a positive test, because back in March there were no tests. And so this is often used as a way to, well, not used, but it can be, it can cast doubt on the whole enterprise of, well, what is the origin of your so there are multiple issues around the interaction between the isolation of the lockdown that I experienced, and their isolation from other support networks that come from being alone, where does make you question what is kind of true within yourself, I guess. Does that make sense?
Yeah, no, that makes sense. Yeah, that's great. Is there anything else, I guess, you could touch on your experiences on, like, how did you overcome that maybe, or when you were going back and forth to the doctors, the hospital, as you said, and they were sort of not really paying attention to that?
I think the turning point was when I decided not to. I split off from the GP that I'd seen initially and kind of got to private referrals myself. I actually paid to see a neurologist privately. And that was probably the most validating part of it, because he said to me, actually, a whole load of other people who are new patients of mine have the same symptoms of you. And yes, we may not know what the underlying cause is, but you're not imagining that this is happening. This is something that's happening to other people. And the other turning point was finding the online support groups, which sprung up as the kind of patient movement really got going when people started to connect with each other back in May. And it's really from there that the long COVID kind of patient-led movement started, where a lot of us got this pushback from the established medical profession. And looking for answers, we found each other. And a lot of the patient-led research is what has led to sort of the validation and construction of long COVID as a condition. So I think being part of that community and being able to speak to other people, other patients who have been through the same experiences in terms of mental health, being in that community has a huge impact on again, it's that validation about not being alone in your experience and feeling supported within the community, which none of us were getting from medicine itself. And obviously now that's changing, but that was a really big point of impact. And I mean, a third point, if I have time, is
of course,
just to say, this is, for a lot of us, this is an ongoing kind of chronic thing now, and obviously we hope that we will eventually recover from long COVID. But there's also a turning point at which you kind of accept that your life has changed a lot, that you aren't living in the same way as you were before. I used to go running every day. I haven't been running for months now, so it's and work and stuff has just completely gone out the window, really. So it's very challenging, but I think there's also a turning point in accepting the situation and working with it, rather than
definitely
fighting to be something or somebody, and kind of turning your attention into what you can do and what you can control.
Amazing. That's really interesting. Thank you for that, because I'm sure a lot of people listening and watching would find that really helpful. People like yourself that's been in that situation. So this is a question, I guess, for all of you. Is there any research around the mental impacts of long COVID? If so, what are these findings?
Might help if I mute myself. But sadly, there's been very little research. There have been some studies finding some cognitive impairments, so memory problems. So the brain fog is a common symptom that's reported, and there are some studies like there was a BBC Horizon study that was doing cognitive studies, and so that coincidentally lots of people got COVID, and they've looked at them. So there's some evidence accumulating. It's only a preprint at the moment, so it's not been published in a peer-reviewed format yet. But so there's sort of evidence to show that that's quite common. In terms of sort of depression, anxiety, they're reported a lot, but we don't have a really good idea of the prevalence of these things, because most of the studies have been like the excellent and really sort of pioneering patient-led research is we don't have a sort of denominator. We know there's a group who've come together who've got a certain number of symptoms. We don't know how typical they are of the whole population, and also full details about exactly what these symptoms are. But I think there's potentially signs of that, and I think Tom might know about the sort of patient-led research as well, but early signs. But it's not really, this is why there's such an urgency to study this. There's lots of reports, but we really need to do proper, robust research to answer that question.
Okay, thanks for that, Tim. Anyone else?
Well, I agree entirely with Tim. We need more research. We need it urgently. Max and I are going back to the database and looking at some longer term outcomes. And obviously, as the evolution of this illness goes on, we're trying to explore this question. Of course, one of the challenges is when you go to health records is that long COVID isn't a diagnosis. Yeah. So it's a matter of question whether how and if doctors are recording it. And we sort of need an official label for a diagnosis. On the other hand, we need the research to tell us what the core of long COVID is, or the long COVIDs are. There may be more than one. And so it's a slightly kind of circular problem at the moment. I think everybody who's experiencing this knows there's clearly something important going on, and we all want to get a handle on it. But it's actually quite difficult to do that in in what will be, in research terms, a robust way of doing it, because we're stuck with a problem that's evolving so fast, whilst you're still trying to study it. It's a bit like the very early days of COVID, when people are trying to work out when are you infectious and et cetera. We've kind of got a better handle on that now. We really still don't have a handle on the long COVID aspect of COVID, because of course it takes longer for that to become clear.
Okay, thank you for that, Paul. Do you have anything on that, Max, you might want to add?
I think everything has been said, really. The bottom line is we need more research, and urgent research.
Okay, that's great. So another question, sort of, I guess this is more for Max and Paul. In regards to the research you guys mentioned earlier on, will there be opportunities to revisit the exact same data, so the 62,000 people, to measure the longer term mental health impacts?
I don't know if you want to answer that one. Yes and no. So yes, in the sense that we can go back to the same data. We can see the patients that were infected during the time period we were looking at. The data set, there's a small caveat to that, which is that the data set that we are using is a live network data set. That is, it's real world data in its purest form, which is, when you see a doctor, that gets populated into the data set. And so we might not have the exact same 62,000, but we can get something very close to that. And so, yes, we are looking at that now and seeing what's happening to those patients.
Okay, that's great. That's good to know. And a final question for you all from myself before we start the Q&A questions. What are the next steps for mental health research to better the understanding of the relationship between mental health problems and COVID-19?
Well, I think obviously we could do more of the kind of stuff we're doing, which has its own strengths and weaknesses. I think what we really need is, first of all, more research in the UK, and we need more targeted studies. And Tim and I, and maybe others on this call, are involved in some of the big UK studies that are trying to follow up people in an appropriately balanced, broad way to assess both mental and physical health as people recover or don't recover from their COVID. And there's a number of studies. There's two big ones, one of which is trying to take a general look at a large number of people. There's then also a more specialized study that Tim's particularly involved with, which is going into the brain and the mental health aspects particularly, and following up people like that in much more detail to really try and get a handle on what are the mechanisms that are going on behind long COVID and other neurological problems after the illness. So I think we're going to need different research of different kinds.
Yeah,
really
definitely.
Get a handle on this.
Okay, that's great. Thank you, Paul. Anyone else, Tim?
Yeah, so just to say that absolutely, there's a lot of research, and we're quite lucky in the UK. I think the funding bodies and sort of institutions have realised the importance of this, and have been quite quick at getting going in funding research. And there's research going on as part of a big sort of more respiratory general health based study that has mental health and sort of focus as well. But then there's this quite big study of the neurological complications, which won't be tackling long COVID, because it'll be focusing mostly on patients who were hospitalised initially, so had severe respiratory and other problems at the start, or were hospitalised for another reason. But at the moment, there's a big £20 million call for funding into long COVID. So very quickly, the government and funding bodies have realised the importance of this, and this is thanks to Tom and his colleagues really raising awareness and lobbying and and it's really a sort of great thing that's occurred. This is the first time patients have mobilised, joined up on their own, and lobbied very successfully for action, and clinicians have come along with them and understood the importance quite quickly. And even though we'd love to have moved faster compared to the rest of the world, we're moving very fast. And MQ have actually been very helpful at supporting these applications. So the COVID-CNS study that I helped put together, led by Ben Michael in Liverpool and Jerome Breen in London, King's in London, MQ were very helpful at sort of supporting the application and sort of, getting behind it. And again, everybody realizing the interconnection of physical and mental health in brain disease.
That's great. Thank you. And Max, do you have anything to add there?
Yeah, I think reiterating what's been said, so we need more research in understanding the mechanisms. We've been mentioning that quite a few times during this webinar. We need some more targeted studies where we know a lot more about the patients. And then I guess another thing to that is, once we have defined the concepts more clearly about long COVID, we have a diagnostic code maybe for it, and we can clearly sort of recruit groups of patients with long COVID. I think the important thing would be to know what sort of treatments are available and what sort of treatment works for those patients. I think that's going to be crucial.
Yeah, okay, that's great. That's great. And finally, Tom, what do you hope research can answer about long COVID?
I think we, as a group, obviously, we really do want to understand the underlying biomechanical mechanisms of long COVID, of why whether it's an aberrant immune response or what, with the intention of obviously getting a treatment. But as well, I think this question of understanding how the mind and how the interaction between the mental aspects of it and the physical chemical disease process interact, because for a lot of us going along with the symptoms, we find that emotional stress, for instance, can trigger the symptoms to relapse. So there's obviously a way that we need to understand how those things interact, so that in treating this in any way we can do better. So hopefully, and I trust with the work of these excellent people and the money that's been put into it, we will find answers sooner rather than later.
That's great. Well, thank you for that, Tom. So now we're going to go over to some questions from the audience, guys. So I'm just going to read some out. Whoever thinks best is to answer these, just throw your answers out there, guys. So first of all, we have a question from Claire. Claire's asked, do you know how representative of the US data were and how applicable and how they are to the UK?
Okay, I can take this. Max may want to chip in. Excuse me. Yeah, we spent quite a lot of time trying to dig into that. Certainly, some American data are limited by the fact they come from patients with insurance. So you're getting data from the better off part of the American population. This database isn't like that. So it's fairly representative, we think, of the whole US population. But the nature of their healthcare means they may well be undersampling or underrepresenting the people at the bottom of the pile, if you like. And that may affect our results in various ways. There may also be some differences in use of diagnostic codes. Although this study used the same diagnostic coding we have in this country, it's possible that American physicians use labels a bit differently to the way British doctors might use them. Yeah. My own sense is those effects are relatively minor. And I would think that the broad conclusions we draw from our study really would probably apply to patients in the UK as well, with those caveats.
Okay, that's great. Thanks for that there, Paul. And now we have another question. This is an anonymous question. So do the panel think that Tom's experience with a GP failing to diagnose long COVID is likely to be reoccurring widely and still in the late 2020s? If so, what needs to be done to educate GPs?
Again, I don't want to hold this, but so my wife's a GP, so I've experienced that firsthand, if you like. I think it's quite tough for GPs and other doctors at the moment. First of all, they're working in such a difficult, stressful environment. Paying full attention to people with complex presentations is a challenge for everybody. It's not an excuse. But I think also doctors are quite conservative, and when people come along with what looks like something new that they don't recognize, it's not something they've been taught, I think there is an inherent conservatism that sounds like people like Tom have suffered from. And that's not to defend it, it's just to say that's just the way it is. And I would hope and expect that GPs and indeed other healthcare professionals' understanding of and views about long COVID will be changing really very much as we speak. And with NICE coming out with guidelines and so on, I think the situation should change. So it doesn't surprise me. And it may well be we do need some education for GPs, that as hopefully the second wave begins to subside and they're not completely preoccupied with the physical health of acute ill patients and the vaccinations, that they can start to pay enough attention to the people with long COVID and similar symptoms, because we can be sure those problems, are going to go on being an issue for some while, even after the acute infections have been got on top of.
Thank you for that, Paul. Anyone else like to add?
Just echo that it's a very difficult, I think a very difficult job doing, seeing patients as quickly and as such complexity as GPs do. But I think hopefully that difficulty in recognising something and taking it seriously is much less than it was. And I think it's thanks to the advocacy of the long COVID SOS. And I think a lot of academic GPs have led the way educating their colleagues. The BMJ has published many articles and correspondence, which have been some of its highest impact publications. So I think the word has really got out. So I think it'd be quite unlikely that it'll be treated in that similar way to it was initially in the second wave and from now on. And I hope that Tom's, the new people joining the group, so hopefully reporting that sort of experience much less than they were.
That's great. Thank you there, Tim. Do anyone else have anything to say to that? If not, we can move on to the next question.
I'd like to add something, if you don't mind.
Yeah, definitely.
Just to say, obviously I kind of have my ears into the community a bit, and I think it's still happening quite a bit, unfortunately. Probably less so than in May, but I've spoken to people fairly recently. I've also spoken to people who perhaps are less persistent and more willing to tolerate difficulty in their physical health, who have been kind of batted away from the GP and aren't receiving that much attention. And I think one of the issues is potentially that there are potentially a lot of people out there with milder presentations of long COVID or issues that have developed subsequently that aren't disabling them completely, but equally aren't. So there may be people presenting with new problems at the GP who perhaps they're perhaps not being identified as being related to the COVID infection. And I think it's a point worth making, which is something that I personally didn't realise until I needed to interact with Western medicine this much. But the GPs, as I think Paul touched on this, the GP is trained to understand a range of conditions that have been researched and already are known. So they diagnose based on that. Whereas as a patient, your approach is, this is an inquiry. I want to understand what's wrong with me and make it better, but for the GP, they just don't have that mindset. So there's somewhere in the middle, we'll get a bit lost and don't quite, our expectations between the expectations of the patients and the capabilities of the GPs perhaps need to be clearly articulated.
I think on the next challenge, I think we can predict that will happen is that even when GPs and everyone else is recognising long COVID, labelling it appropriately, they're going to say, now what am I supposed to do about it?
Right.
I think there's going to be a frustrating time when even when we all recognise it, it's got a label, doctors diagnose it when it's present, then they're going to be throwing their hands up, looking, well, to people like us and beyond, and who knows who else to actually be able to intervene. Because, of course, we don't know its natural history, as Tom said. If we're lucky, it'll be self-limiting. If we're not lucky, then that's going to be a real challenge for medicine to both evaluate and then provide whatever treatments turn out to be effective for sufferers.
I think on a positive note, services, there was £10 million, which sounds like a lot, but actually doesn't go terribly far given the number of patients. But there are 40 clinics being set up across the UK as we speak. I think there's there was a pioneering clinic at UCL. I think now every sort of big section of the country will have its own clinic. Everyone will, hopefully a multidisciplinary clinic to deal with what will probably be quite a heterogeneous sort of potentially group of disorders, not just one disorder. So I think that those are starting, but I think that's it's not going to go far, given I think the number of patients who I think will be presenting, but that'll really help GPs that they've got someone they can send to, and will start to get experience about how to assess and how to treat, hopefully, these patients. But the research is going to take a while to feed into knowledge about treatments and build up an evidence base for what to do. But I think having a service, a specialist service that'll learn as it goes along a bit, is a massive start.
My own view, and I don't know if other people would agree with this, is I think we should view this like we viewed with the first episode of COVID. The norm should be patients go into trials. So it becomes a collaborative investigation from day one. We say, well, here are some potentially plausible treatments for long COVID. Go into that, and as soon as it shows that one intervention is ineffective, you drop it, you move on to something else. So building what will be called adaptive clinical trials into these long COVID hubs, I think, in the long run will be of greatest value to everybody, because you can guarantee some of the things we think are going to work won't. The other things that come along that we wouldn't have thought of that may turn out to
will
be great.
work. Yeah.
And we've got to have the right mindset, both I think as professionals, but also as sufferers, that it is a collaborative venture to try and get on top of this problem as quickly and as effectively as we can.
Yeah, that's great. Thank you there, Paul, for that. But we also have a question off Eileen. Eileen says, I'm a service user in mental health and I'm interested in the effect on the brain. It might be confusing at my age, 72, to distinguish. That's a great point. If you found any differences on the effect of mental health patients depending on their age.
Max, did you want to come in there?
Yeah, so we did find the fact that the association that we were talking about earlier, which is that people with a mental health diagnosis are more likely to get COVID, that this was even more so among the older patients. That is to say, we know that older people are more likely to get COVID, but they're even more likely, if you will, to have COVID if they have a psychiatric illness. And so there's a compounding effect of the mental illness in the older people on the chance and the risk of having COVID.
I think the other aspect of Ian's question might be, if you've had COVID and you're elderly, are you more likely to get the mental health consequences of it? It's not something we really explored in any detail in that first study, but it's certainly something in our next study where we're aware that age is such an important factor. We need to explore whether there's an interaction between age and the mental health risks after COVID, and indeed the long COVID risks after COVID. I'm not aware of any data about whether age might or might not be a vulnerability factor in that regard. Just another question we need to find an answer to.
Definitely.
I think it's not sort of a robust sort of epidemiological data, but the coroner surveillance study found that neurological complications were much more common in the elderly, but the psychiatric complications were occurring in a younger age group, so sort of more of a mean age of 50 rather than the 60s, 70s, which strokes and other such complications were occurring in. The other thing with age, with the delirium, so that acute sort of confusion state is very common in elderly patients, and I think, as I briefly mentioned earlier on, can be the only presenting feature. So somebody who's in a care home or very elderly, if they become confused but then don't have respiratory compromise, it might be a very clear sign that they might have COVID and need testing and looking out for, because obviously they might deteriorate quite rapidly. And it's and delirium is used to be thought of as a sort of unusual side effect of having an illness, but it's a very severe illness in its own right, and needs to be taken as a medical emergency and screened for in the elderly population.
Okay, that's great. Thank you for that there, Tim. So we also have another question here. So we have to have a balance with mental health socially and isolation. Do any of you think the social isolations could be a contributing factor to the increase in mental health diagnoses?
Well, again, I'm sort of coming first, but I think social isolation and a number of the other effects of the COVID environment we've lived in the lockdown in various flavours, I think for the majority of people that is a bad thing for mental health, not a good thing. And I'm quite sure that those sort of insidious pressures that people have been living under for the last 9 months or whatever are contributing. It's also noticeable that fewer people have been presenting with their mental health problems. I think we've heard that anecdotally, but again, buried somewhere in the appendix of our first study in the US, there's been almost a third less people receiving psychiatric diagnoses in the whole population. And that's true across the whole of medicine. So it's unlikely there's a third less people with the problems. It's almost certainly there's at least as many people with problems who are not getting diagnosed and therefore not getting treated. So I think, unfortunately, although our study was only looking at COVID survivors, there's a more general point about everybody's mental health in the era of COVID, where you have this double whammy of having less health services available and a greater reluctance to go seek. And when you do, the services are so overwhelmed with COVID, they may be less able to give you the time and the attention to treat your mental health problems. So I think there's bound to be some of that going on. Again, one hopes that settles down fairly quickly, but I worry that the kind of ripples of the effects on the health system of COVID are going to go on for quite some time before we get back even to the levels of service we had before.
Yeah, definitely. Do anyone else want to add anything into regards to that one?
I was just going to say that I think it's very complicated, the effects of social changes that are occurring. I think some patients I know who are used to life on their own because of severe illness, that whether it's physical or mental health disorders, that there isn't a huge change. But I think also sometimes not only isolation, it's being stuck indoors if you've got difficult lives, difficult relationships, that can sort of fracture. And it wouldn't be surprising, I don't know the data on it, whether we start to see rates of separation, divorce problems occurring quite a lot as a result of being, not having the same ability to, being stuck indoors during lockdown. So I think that's interesting, and I don't know if there's any data on that. And I don't know the details of it. I think there was a study from Japan showing quite high rates of suicide recently. I don't know if Paul or Max know the data from that, but it's certainly a bit of a press around that recently in the last week.
No, I was aware of a big Australian study that in fact hadn't found any effect of suicide. But I guess
specific to cultures and situations.
Absolutely, I think that's definitely likely.
I think there is a delayed response of suicide to any sort of mental illness event and public health emergencies, and so that's something that was discussed in a meeting in the US a couple of weeks ago, because the Greek have just published a study showing that there was no increase in suicide rates, but it might well be that we need to look at that in the longer term, and that might reconcile sort of what seems apparently to be contradictory findings from different countries. And it might well be that there is a cultural difference, but it might also be that depending on where they are compared to the pandemic, the rate overall, if we look at 2-3 years down the line, is increasing in all countries.
Definitely. Thank you for that there, Max. So Hannah asked, Paul mentioned that there are a few research projects going on. Is there any way for people who have had COVID to volunteer to take part in this? And if so, what would the process be?
I think for the two studies that have started already, that may be difficult in that they generally, there'll be a kind of a time delay, there'll be a limited time between your COVID and being able to be enrolled in the study. The first big study, for example, requires that you were in hospital for 48 hours at least when you had your COVID. So that rather rules out the people who didn't need that level of intervention. But I think the long COVID study or studies that Tim's alluded to will probably be, again, Tim, you may know more than I do, that it might well be more opportunity for people, even if they had their COVID a while ago and it wasn't too bad at the time, to take part. But again, Tim, you'll know more than I do.
Absolutely. I think the neurological complication study, the COVID-CNS study, is not. You don't have to be an inpatient or have been an inpatient to be recruited into it, but it would need sort of severe, relatively severe neurological or neuropsychiatric complication to take part. But obviously, that's hopefully starting up in the new year. There are several other studies underway, and we should try and put some links if we can on the MQ website if there's studies that are potentially relevant. But the long COVID studies, when the applications are going in next week, and studies are supposed to be starting at the end of January. So from the end of January onwards, there should be there's going to be £20 million worth of research starting up, which in research terms is a huge amount of research all at the same time. So it's certainly something to keep an eye out for if people have long COVID, because there'll be lots of people, and they'll have studies will have different methods. So some will be open to anybody applying to join and with certain criteria. Others you'll need to be in a certain GP practice or or a certain sort of secondary care or other setting to be recruited. So, but certainly a lot going on, and very happy to take any emails or contacts about anybody who's interested in taking part.
Okay, that's great. That's good to know. And for all our watchers, obviously, that's good to know, as Dr. Tim have said. So thanks for your question there, Hannah. So you can answer those questions on MQ's participant platform too. You can take part in a range of different studies, including many that can relate to COVID. We'll post a link in the chat though too. So if you need to get in touch with that, like Dr. Tim said, and so on, there's research studies there. So we have a final question here from the audience by Russell. So Russell asks, now there is a vaccine that is being rolled out. Will this project and protect against any long COVID as well? And is there any risk that the vaccine could cause long COVID systems with regards to mental health?
Tricky one. Yeah. I guess thinking logically about it, if the vaccine stops you getting COVID, then you won't get long COVID. But obviously we know it's not, most of the vaccines aren't 100% effective. So, and there's, still, even though there's good preliminary data about this, it's not borne out yet. And, but I think overwhelmingly the vaccines will be, any potential side effects or problems will be massively outweighed by the potential benefits of not getting COVID in the first place. So I think, I don't personally think there's any particular concerns there.
That's great, thank you.
Vaccines in general have an amazingly good track record. I mean, I know there's often worries about them. There's been one or two scares, but generally, they're even better than antibiotics. I mean, they really do. For the vast majority of people, they are fantastic. And I would again, in terms of everything in life has risks.
Yeah,
I would be very confident that any vaccine that receives regulatory approval, we have to trust the regulators. I would trust them completely, and I would roll my arm up and have a vaccine tomorrow, whichever one it is. I would say that the chances it's going to harm me are infinitely small compared to the chance it's going to protect me, not only from COVID but from long COVID.
Yeah, definitely. That's great. Thank you so much for that there, Paul. So that's all about we have time for this evening. So thank you to everyone for coming and for all our guests for this fascinating MQ Open Mind. A big thank you to everyone who donated also for their ticket, as MQ is a charity and we do rely on the generosity of the public to fund the next mental health breakthrough. So if you're able to donate using the link shared in the chat, Bryony will send that around so you can all get on that link. So just to end up to also, guys, you can also follow MQ on any social media platform at MQ Mental Health. You can also follow me. I'm Talk to Coco at Talk to Coco on Instagram, Tim at Tim_R_Nicholson on Twitter, at Long COVID SOS, and the Neuropsych of COVID blog at Neuropsych COVID, and Max on Maxime. So let me spell Max's name for you, at MAXIMETAQUET. That's great, and thanks for everyone for joining us. Have a lovely evening. Bye.
Thank you.